Nick Majerison here. Welcome along to Top Med Talk. And it's time for a brand new series here on Top Med Talk. It's TRIPOM, trainees with an interest in perioperative medicine. They're reporting from the EBPOM USA Dallas Masters course, Perioperative Care Practicum, which happened, of course, in March of this year, March the 22nd to the 24th. Make sure you check out ebpom.org/meetings to find out more details of meetings that are being arranged around the world as part of evidence-based perioperative medicine. ebpom.org/meetings. In the meantime, let's have a listen to TRIPOM.
Top Med Talk.
All right, we're back at EBPOM Dallas 2019. We are continuing the conversation that we started about obstetric anesthesia, surgery, ERAS, how to streamline these patients to both improve outcomes, decrease length of stay, and improve satisfaction. We are here with Mark Zakowski. Go ahead and introduce yourself, sir.
Oh, thank you for having me. I am currently president for SOAP, the Society for Obstetric, Anesthesia, and Perinatology, and I'm practice at Cedars-Sinai in Los Angeles, where I'm chief of OB anesthesia.
Sir, it's an honor to have you here. Thank you for joining us.
My pleasure.
All right, and we also have Marcus.
Hi, thank you for having me here. I'm a third-year medical student from St. George's University, and currently I'm doing my core rotations in New Jersey at St. Peter's Hospital, and I'm working on this research project with Dr. Ket, who gave you guys a talk before this, and I'm doing mostly data mining for him and running statistical analysis on the data that we're getting.
That's great. So you're getting the down and the dirty. You're getting the good stuff.
You can
meat
definitely
and potatoes,
say that.
so to speak. That's fantastic.
Thank you.
So starting with you, Dr. Zakowski, from a leadership perspective, is this going to be standard of care, OB-ERAS? Is this something that we would be recommending to implement across the nation? Or?
So I was instrumental as part of my presidency. I pushed, and we are coming out with a SOAP, Enhanced Recovery After Cesarean Guidelines. Should be out in about 6 weeks or so, up on the website for everybody, so that it can be a template, easy to use for people. So yes, it should be popular. That word standard of care is a tricky word, because if you don't do it, that has some medical legal implications. So let's just say best practices. And SOAP, the mission is to improve the outcomes and care for moms and their newborn through education, research, and improving clinical care, so it's aligned with the SOAP's mission.
That's fantastic. I'm looking forward to seeing that. I think that'll be great.
And what are the guidelines going to touch on? I mean, does it cover everything from analgesia to fluid management? Does it cover, say, emergency cesarean sections?
To implement, you can certainly implement most of it if it's a non-elective cesarean, but the guidelines are geared to start with the elective cesarean section. And compared to, say, the guidelines that were put out by ACOG or other organizations which are more global, specifically, we were able to get a little more down into the weeds and be a little more prescriptive about don't go above, sort of what's considered lower dose neuraxial narcotic, a maximum between 50 and 150 micrograms of intrathecal morphine and 1 to 3 milligrams of epidural morphine. And, we're able to guide people a bit more on the dosing for stuff.
That's great. Are you aware? Is SOAP? I guess know how many people across the country are implementing something similar to an OB-ERAS protocol by chance?
Well, a lot of people are starting one now. I put it as head of the task force 2 people who are a couple years ahead of the curve. Dr. Bolak from University of Washington, and Dr. Tiarine from University of Virginia. So, and we have experts from across the country, but more and more of our colleagues are implementing it, yes.
Fantastic. Is data going to be collected from all these different institutions that are going to be implementing the ERAS into a central database to kind of examine what changes have helped, what needs to be improved still?
Well, I hope so. That's one goal for SOAP, which is to have a database that collects from all our members and institutions. Currently, we're fundraising to fund that project. So if you have any corporate sponsors, send them my way.
Not yet. All right. And speaking of going through data, I know that you've been doing a lot of that, Marcus. Tell us about that.
Yes, so I've been getting a lot of data that we acquired from both control patients as well as our patients who are going through the ERAS study that has been given to me through the IT department as well that we have been collecting. And the missing variables that we also want to take a look at, I've been going through patients' medical records and I'm trying to extract them and put them all together. So we have a standard pool of data with all the variables that we're trying to test and look for, which varies from basically how much fluids did they get, how long was their length of stay, how long was the procedure, and it all varies, which medications did they get. And so basically use all of those variables and run them through each other as in ERAS patients versus the controls and see which variables are having significant effect, and also just to imply that if the studies, if ERAS is having a big effect compared to regular patients who are going through the procedures and patients who are going through the ERAS study, and see what's going on. And also a lot of papers that I came across, they were mostly, since the studies got switched from at most institutions, they got switched to just ERAS, going from regular, and then they implemented the ERAS pathway. A lot of their study has been showing that they're analyzing the variables within the ERAS groups as to combining that whole data and as simultaneously on the other side where they have actual controls or regular patients who are going through this procedure and comparing the two together. So what we're trying to do here is actually, since we have those patients who are going through the regular procedure as well as ERAS enhanced procedure, we're trying to simultaneously run them across through to see what variations we will see, and then recommend which variables that can be having an effect on these recovery of these patients.
So when you're doing these analyses, are you doing some subgroup analyses going forward to look for secondary outcomes of anything of interest, anything in particular?
Yes, there are potential other subsets that we might be dividing the data into. There are always, like it was mentioned in the previous study, the patients who actually went through the study first time now are having their second babies and they want to go through the ERAS study. So we're potentially looking into seeing the significance of recovery based on, hey, is it their first parity or their second parity? So try to subset them as well according to that area as well. So that's something that's coming in the future.
It's almost like a crossover study in a sense.
Yeah, it could be. It has a lot of variables that we have to figure out. So keep it simple first and then try to subgroup them accordingly and then analyze them further.
So, Mark, if I can just ask you, if you had 3 recommendations for institutions that don't have an OB ERAS pathway or trainees who are just curious, what 3 recommendations can we implement right now?
Great question. So you want to look at the big picture, right? Which is, we know 1 in 3 opioid naive women having a cesarean section will wind up using narcotics longer term. So one of the benefits of ERAS, or at least the basic components, is to decrease opioid consumption. So one of the things is to have scheduled acetaminophen and an NSAID of your choice. Which one doesn't really matter. That alone will reduce opioid consumption by 30%. That was a paper from Stanford. So that's a very simple step everybody can do tomorrow. That's one thing. Then there's components about intra-op, how to maintain both normothermia, use of prophylactic vasopressor infusion to reduce intra-op hypotension, which is a cause of nausea vomiting. Globally, once you get into the nausea vomiting loop, that sort of inhibits recovery and the eating, drinking quickly afterwards. Key is mobilization, mother-baby bonding. Another sticking point can be separate out discharge criteria. Traditionally, mom's not ready, baby's not ready, we'll stay another day. Each has to be discharged based on their own criteria, and then you set up a way for mom to hang out with baby or take care of that so you don't get extra length of stay that's unnecessary.
And where can people learn more about this that's going to be coming out?
It will be up on the SOAP website, soap.org. We're not just clean and reduce infections, but there's a lot. And one of the things I tried to do this year as president is really to extend out the umbrella. People think of SOAP as a little bit of an academic-ish organization, and I've really tried to reach out so that we include all practitioners that provide obstetric anesthesia, whether academic, private practice, nurse anesthetist, anybody, because we want you to be part of the family and be educated on what are the best practices, because, best practices and what's current keeps changing.
Well, thank you guys. We really appreciate the time. This is very interesting stuff. And please, everyone that's listening that's not able to be here at EBPOM 2019, go to SOAP, check it out.
Please join.
Recommendations? Yes, and please join. And trainees interested in perioperative medicine signing off, please come check us out at tripom.org. Sign up. Get involved. We can do better, folks.
Resident membership is free.
Thank you so much, guys.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.